Hi, my name is Lisa Ray Thomas, and I'm a member of the Tlingit Tribes. I'm with the University of Washington Addictions, Drug and Alcohol Institute, and also so grateful to be a consultant with the American Indian Health Commission of Washington State, who has partnered with us in this 5-part series. Today we are, the topic is, we have really 2 topics, responding to some requests from all of you. Innovations and best practices for whole person care for people with behavioral health needs and working with American Indian Alaska Native partners. And then regarding the health of American Indian Alaska Native pregnant, birthing, and postpartum people. And I'm going to turn it over to Vicki and Catherine from the commission. I'm also going to turn off my video so that I can monitor the chat. If you have questions and comments during the presentation, please enter them in the chat and I will grab all of them, put them into a Word document in case we're not able to get to them today. So with that, Catherine, thank you and welcome.
Thank you so much. Catherine Akia. Good day, my name is Catherine Akia and I'm a tribal health consultant with American Indian Health Commission. Really happy to be here. I am here in Olympia on Coast Salish land. I'm originally from the other side though, I'm Yakama and Dene. So it's always good to be around people and to see a variety of faces and names, and some of them are recognizing from previous sessions. So glad to be here and glad to talk to you all today. And with that, I'll let Vicki introduce herself as well.
Hi, Swatchy. Good afternoon. Vicki Lowe, Snastatitlum New Sklyans and Snanuhak. My name is Vicki Lowe. I'm Jamestown Squaw. I'm in Bella Coola First Nations. And I have the great pleasure of working on behalf of the 29 tribes and urban Indian health programs and Indian healthcare providers in Washington State as the executive director of the American Indian Health Commission. And I just want to give my appreciation to you, Deb, and to Lisa Ray Thomas and team for really bringing this together for us. And for those of you who are participating, you know, this is really important work at educating each other on how to work together. So I'm just very excited about the work that we've done together and to be able to bring this this 5th in the series of trainings for you all. So I'm not sure who I'm handing it off to. Is it back to you, Catherine?
Actually, Cindy's. We'll hand it to Cindy next. And I've got slides up, and Cindy, just let me know when you want advanced slides. I'll do that.
So Cindy Gamble is here, and I'll let you introduce yourself, Cindy.
Hey, thank you so much. Cindy Gamble, a member of the Tlingit Nation in Southeast Alaska. I'm a tribal community health consultant with the American Indian Health Commission. And so I'd just like to jump in if that's okay. So next slide. We started out and we had a little MIH segment in the unique aspects of the Indian healthcare delivery system a few sessions ago. And just to ground us here, we talked about the fact that we always had our own healthcare system. We had plant and animal medicine, we had ceremonies. We also talked about the sacredness and the importance of the role of being a life giver. And that means the birth of a child means that the people will continue. And you've had a lot of sessions that talked about our 500 years of experience and what's happened, some of the historical trauma. I don't want to go through all of that again, except to say that I do have to call attention to the sterilization trauma that happened to American Indian Alaska Native women without their knowledge or consent in the 1960s by the Indian Health Service, the agency that is supposed to ensure our health and improve our health. And so all of these things that you've learned about in all of these sessions have resulted in these disparities, such as this disparity here, highlighted with the arrow that comes, which is Washington State maternal mortality data. Okay, next slide. So we wanted to talk about something that's more positive and what is more current, what is really happening now. But before we go to those innovations, I wanted to just share something that was really important learning that I had that I think will really help inform the rest of what I'm going to talk about. And that is 30 plus years ago when I was a young mom with young kids living in Southeast Alaska on Prince of Wales Island. I was invited to join a women's book club. And this was a book, The Sacred Hoot, that they chose for us to read by Paula Gunn Allen. And, you know, I don't know if you've gone to these book clubs before, but, you know, gather together and we eat and then we start visiting. And I don't even know if we ever really finished the book, but I myself was very grateful to be exposed to it and to learn from it. And it was in the 1980s. And so there was a lot of talk about the renaissance of tribes and American Indians, Alaska Natives, the renaissance of our culture and our cultural ways. And there were things that were missing, like I didn't really see the word colonize or colonization in there, but she did use this word gynocratic a lot, pertaining to government, women being involved in government. So next slide, please. And, you know, as I was a child growing up in Klawock, Alaska, as I grew up, as I became a teenager and then a young college student, I always wondered, why does this society disdain us so much? Why are they so not accepting of our ways and our beliefs? Why do we have to hide some of these things? You know, what are they threatened about? I had these questions. And so it was very, and I also was very curious about, because we're oral tradition people, we didn't have written histories. I was very curious about what lifestyle was like back in the day. And so this was really interesting to me to hear her say traditional tribal lifestyles are more often gynocratic than not, and they are never patriarchal. And that's a very strong statement. They are never patriarchal because, of course, right now in the Western US society that we're living in now, it's a strongly patriarchal system. So right then is a little, you see there's a little bumping of lifestyles there. And it's also interesting to me that she says when women are involved in the decision-making and governance, it makes a big difference in how societies are run and the quality of life, not only for Mother Earth and all of our relatives, all of her children, but, you know, all of us, all of the one-legged, two-legged, and four-legged, and it makes a big difference. Okay, next slide, please. And then really interesting to have her list what features of gynocratic societies are, that there's just such an acceptance of who a person is. There is a large diversity of roles. And she talked about how gay, lesbian, bisexual people were accepted. They had important and special roles in our tribal societies. She didn't talk about trans and non-binary. I think that wasn't talked about. We didn't have those words back then, but just really clearly that there is a lack of expectation of what is female and what is male and those roles that you have to stick in. Also that the systems are based on social responsibility and equal distribution of goods. And you know, that's one of the reasons we understood that our potlatch is one of our important ceremonies were outlawed, because the wealth was determined by how much you gave away. And so you were a wealthy person if you and your clan were able to gift and give away and acknowledge whatever the ceremony was. And that was really hard for people to understand. Other features, lack of punitiveness, there wasn't jail, there wasn't punishment. And one of these that is so important, that the welfare of the young is paramount. And that's how I grew up. That's how my parents, my aunties and uncles, the community treated us, is that they looked out for us, and that was important. And again, the acceptance of all life forms. And just acknowledge women, powerful women were a part of social well-being. Okay, next slide. And so you might see where this is going, and what she said that really resonated with me, and that is the physical and cultural genocide of American Indian tribes was and is mostly about patriarchal fear of gynocracy. So that is just, that's a very strong statement. But again, it helped explain so much. And when you contrast those features of those type of societies to our society now, you look at how women and children are treated and our health disparities there, and you can see now why we had some of these problems and why there was a lack of understanding about our beliefs. So next slide, please. So, and you see that this continues. So back in the day, we're oral tradition people. We don't have a lot of written history, but back on the lower left, there is Pretty Nose, who was a war chief of the Arapaho. To the right is Pine Leaf, who was a chief of the Crow. And then I would be really, I'd really be bad if I didn't acknowledge one of the very important female leaders in my own tribe, Elizabeth Pradovich, who is credited with getting Alaska's equal rights law passed 10 years before the US passed their equal rights law with Martin Luther King and all of his social justice warriors. But here in our mainstream society, we still talk about the very first female vice president, the very first female speaker of the House, the first Native American who was elected to Congress, the first, or actually the second Native American who was elected to the Washington State House of Representatives. We still note those. And so again, you see that clash of belief and culture. So next slide, please. So I think one of the innovations that I can talk about is just really that we survived, and in a recent rap song that I was listening to with my son, the words were, the resistance, no, I got it wrong. Our existence is our resistance. And I just love that. So we've found that the innovation is survival, and the innovation is knowing that we have to go back to our roots, to our traditional ways. And the innovation is that they have still survived those 500 plus years when we had to when we went through all the trauma we went through, and all of this had to survive through oral teachings. So when we look at things on the national movement, again, these start locally in communities with tribal and urban Indian leaders. They are shared, and all of a sudden they just catch fire in Indian country, and then they are movement. So many people are concerned in Indian country about the maternal mortality rates, that our disparities are pretty bad. And so the National Indian Health Board is actually right now looking at the feasibility of having tribal-led maternal mortality review committees. Food sovereignty, the movement is just so important, all of those years of starvation, of being underfed in boarding schools, of being fed nutrient poor foods, with the food distribution, government food distribution system. We need nutrient dense food. We need the food, our soul food, the food that feeds our bodies and souls. And it's so important to the health of our women and children, and of course our families. And every year there is this National Food Sovereignty Conference, the Seeds of Native Health. It is amazing to be there and learn from the other tribes and communities what they're doing, their brilliant ideas. It's just wonderful. Another one is the Indigenous Birth Workers Movement, and that has just been, it's just an amazing movement. I've been to several of their gatherings. These are midwives, community midwives, they are doulas, they are lactation consultants, childbirth educators, people who support this across the US and Canada. And when they gather and learn from one another, it's amazing to be there. And again, a part of our health and healing is how we live with this land, how our mother is treated. And so respectful and tribal ecological land management is really important. as we have Standing Rock, the water protectors, in Indian country, we knew about the water protectors weeks and months before it became on mainstream media. But there are other protectors too, other people who are working to protect the water, the land, the trees, the animals in their communities. And again, that is part of our overall health. There is a National Indian and Native American WIC coalition. They gather every other year, these Indian tribal organizations. WIC is such an important program in our communities. It's one of in small communities, it can be the only MIH program supporting program. And so this NINAC gathering to learn from one another is really important. And then all the language revitalization that's happening, and it might seem a stretch for maternal infant health, but when our soul feels good and we have the words to express what we are going through, it makes a difference to our health. Next slide, please. And in Washington State, at the government and leadership level, again, these things start at the tribal and urban Indian community level. They have things that are going on to support maternal infant health. And one of the really important things they did, I think 27, 28 years ago, was create the American Indian Health Commission, which has the mission of improving the health status of American Indian Alaska Natives in Washington State. And one of our definitely foundational and priorities is maternal and infant health, something we've worked on for a long time. The Northwest Portland Area Indian Health Board, they are very important with the work that they do. They have an epicenter, they gather maternal infant health data for us to look at, and they have they started a tribal breastfeeding coalition across the 3 states. They have breastfeeding classes that I hope I get to talk a little bit more about. And because of the tribal and urban Indian leaders and advocacy, the state agencies have responded in having more tribal liaisons, more emphasis on people looking at equity and social justice, actually having grants and funding so that the tribes and urban communities can do some of these, enact and implement some of these ideas to improve maternal infant health in their communities. Next slide, please. I'm trying to look at my timer, so I'm respectful. Really quickly, one of the recent projects that we just completed, the American Indian Health Commission, funded by Department of Health, were these community conversations. We've held 5 virtual statewide conversations with community members, which then informed conversations with the tribal and urban Indian leaders, which then informed, next slide, please, recommendations, which culminated in an American Indian Alaska Native addendum to the 2023 maternal mortality review panel's report to the legislature. So it was an amazing process to listen to our communities and our leaders talk about the issues around maternal health, their concerns, their fears, their needs. It was really important. Next slide, please. And we're very happy and we'll continue that. And then in our state, we're really lucky that we have all of these grassroots movement. The Center for Indigenous Midwifery, just an incredible organization. They do the childbirth education classes, birthing assistant classes, the Indigenous childbirth education classes. We have some of those are from the Center of Indigenous Midwifery. Some of those are from Cami Goldhammer, the first Native IBCLC in Washington State. She's doing some incredible work also there with childbirth education, with lactation, with breastfeeding, and with doula training. So we also have, again, things that are happening at the tribal and urban Indian health organization level, including this Tatawak Birth Justice Center in Yakima. They have been working, I don't know, for 5 or 10 years. They were gathering data, they formed, and now where they are is that they have a board, they have a birth center, which they don't give birth yet, but they have a doctor who comes and does prenatal care there 1 day a week. So they're offering prenatal care appointments there at their tribe, which is just incredible. So there is a lot of grassroots movement. There is a birth justice network of tribes that are getting support to enact how they want to support maternal and infant health in their communities. Next slide, please. So I just want to highlight the Center for Indigenous Midwifery. Rhonda Grants, I'm here shown here. Cowlitz, she is just an incredible person. She founded, she is a community midwife, has done hundreds of births. She teaches across the country and in Canada. She co-founded the Canoe Journey Herbalist. She's a well-practiced herbalist too. Just, I mean, she's young and she's just so knowledgeable. So you see their mission and their vision that they are going to heal generations through midwifery care and taking care, making sure our women and children have a good start. And so it's just amazing. All of the classes, they have something going on all the time. So next slide, please. This is one of their, was on one of their Facebook posts, and I hope I have this correct, but you see breastfeeding is a ceremony, birth is a ceremony, breastfeeding is sacred, and postpartum is forever. And that's just so powerful. And again, you make that contrast of birth is a ceremony towards how it is in our hospitals, where birth is something that is medically managed in and out as quick as you can be. We don't give the time and respect to this experience of the mother and baby. Birth is a ceremony. Next slide, please. So you see the common themes that we have on these national movements that I've highlighted, what's happening in our state at the government leadership level and at the grassroots level. Is it so important that these initiatives are tribal led, that it's just a critical requirement. And you see that all of these things are centered around our culture and our traditions. Our innovation is that they have survived, and we have the good sense and wisdom to go back to that wisdom and knowledge of our ancestors. They include ceremonies and prayer. It's not about how much time is this appointment. It's about how much time it takes, and giving thanks and asking for guidance. Traditional foods and medicines, again, so important, as are our kinships, and healing and indigenous or trauma-informed has to be built in essential. I'm running out of time. Next slide, please. Next slide. So we started out with the voice of an elder scholar. Oh, can you go back to the one before? And just to talk about how we've moved to now acknowledging that women's ceremonies are not a response to colonization, but again, they are just a part of who we are. So thank you very much for this time with you. Ganesh Chish.
Thank you. And I don't want to rush you, Cindy, because it's such amazing and important information. And I really feel grateful. And it was fun. I saw the pictures there and I'm like, I know her.
Yes. Well, language revitalization is really important. And so as an elder, I'm the generation who wasn't able to learn language as I should have. And so a new dawn, Suha Katkewa'a, and it just seemed appropriate to end here. Thank you.
Yeah, I love that. And I absolutely agree. Language has been, it's been tough. It wasn't also I'm part of it. I felt a little bit of jealousy in like the good way, not that I'm mad about it, but that I want to support the younger folks now who are able to grow up and attend some classes. And I see things, innovative things like schools that are offering language credit for Indigenous languages. And there's some great stuff going on. I do feel like we're on an upswing and stuff. So thank you so much for sharing those examples. Now we'll start the second topic. Clicked clicked on the wrong thing. There we go. So we'll start the clip. This is circling back to a topic that was introduced in September, and we said we'd bring back some more information about it, particularly about behavioral health systems, tribal behavioral health systems, some of the work that's been going on around crisis response. And then I'm very excited after I give a quick overview of that we have some folks to talk to with you specifically about some of the work that they do at their facilities and how they work with people, and would like to share that with everyone. So we're excited to be doing this. Just as a reminder, these are the tribe and health clinics across the state. Many of the tribes have behavioral health departments or behavioral health programs that they are working with. They coordinate care. They're working with people, they're seeing people for a variety of services, and then sometimes coordinating care outside the tribe as well, depending on the issues or the needs as they arise. Many of the tribes also work towards wraparound services and whole person care. So that's definitely one of the topics we're going to be asking about to our two panel members. And we just wanted to give you kind of a sense of where they are. Now, this doesn't mean that's only their service area. Some of the tribes have large service areas. They'll make sure to help coordinate and arrange care for people up to, several counties away, depending on where they are and depending on the tribe's eligibility requirements and the role that they play. So one thing we brought up earlier, and this is just a quick reminder, that Indian healthcare providers, which is this umbrella term for both tribal health programs as well as urban Indian health organizations. In this sense, when we're looking at crisis response particularly, we're looking at Indian healthcare providers both as a provider of health services and as a government entity and a governmental authority that has a government-to-government relationship with the state of Washington and with others. And so I just wanted to bring that up because it is kind of important when thinking about why crisis response rolls out the way it does and how that is working. So diving a little deeper into some of the things that have been happening in the last few years, tribal behavioral health crisis response activities have included everything from the Tribal Centric Behavioral Health Advisory Board, which has looked at a ENT facility, the feasibility of an ENT facility, as well as has offered a lot of guidance into the state's changes. So the state has been working on a system-wide crisis assessment, crisis system assessment, as well as recommendations for how to roll out 988 and where all of those systems are going to interface. So that board is also giving some strategic direction with related to how it interfaces with tribes. There have been legislative changes in the last few years. We talked about those. We talked about the Indian Behavioral Health Act. There have been trainings, multiple trainings, so trainings like today, but also training specifically at Designated Crisis Responder Academy, Forensic Navigators, and other providers. There have been templates developed around codes and crisis coordination plans. The Washington Indian Behavioral Health Crisis Hub is up and running now and can serve as a resource and a place for to assist with coordination or finding services for people. Native and Strong Lifeline is up and running now, which is exciting. Bravo to them. They've got a whole crew there of people who can answer the phone and take calls through the 988 system. People calling 988 with Washington area codes will get a dial pad 4 option as they listen to the first message. And if they push 4, they will get straight into the Native and Strong Lifeline counselors. Additionally, there have been various meetings at tribes across the state with regards to designated crisis responders, as well as mobile crisis teams, crisis triage, and crisis respite. So all of these ideas are out there. Tribes provide a number of services already. They're just not recognized in the same way as the state services are. And so looking at not only making sure that those doors are open, that coordination is happening, but also that tribes are then compensated for that work that they're doing. We also have been looking at the implementation of DCR protocols, information gathering with a variety of sources, everything from attorneys to judges to law enforcement to EMS to evaluation treatment facilities, you name it. And then of course, sustainability planning. How do we support this system going forward? I'll do this one quickly. This is just an idea of what it might look like if you are in the behavioral health field and you are interacting with a tribe, either with a tribal designated crisis responder or a mobile crisis team. Some of the parts could look very familiar to you with regards to assessment and reaching outreach and meeting that person. And some of the processes might look different depending on the tribe that you're working with, whether or not they go through an internal process, or if those services might be dispatched directly from, say, the Native and Strong Lifeline. There could be some differences in the process, but just to know that they're out there and that they are available, and that right now the tribes are in different levels of planning for expanding into these types of services. Just a couple of takeaways before we introduce our panelists. Things that we have learned in the work that we've been working with to expand crisis services, and that is several notions around getting comfortable talking about tribal affiliation, that it's not necessarily, you're not asking somebody a race question. This is about a political affiliation and an access to services. So getting people comfortable with that, honoring the Indian healthcare provider, once again, that umbrella term, but honoring the Indian healthcare provider as the health home, as the medical home, using that medical home model with a single entity that's kind of the centralized care coordinator. And also honoring any plans that are in the works. Oops. Almost. The crisis coordination plans, either current ones or the new updated ones, building relationships with providers in your area, and being ready to refer to culturally appropriate services. We realize that everybody on these learning series are in different places in the system, and so we want that to be part of what you do. So with that, I would love to bring on our panelists. So we have behavioral health and family service panelists. We have Charlene Abrahamson today with the Family Services Director for Squaxin Island Tribe. So excited to have Charlene here. And we have Donald Valmer from Digualich Wellness Center, Swinomish Tribal Community, who is the Associate Medical Director. Yeah. And I have prepared for them today a couple of questions. I'll give them there, but I'd love to have them take the questions, but also do just a quick intro to let us know a little bit more about themselves. And I will turn it over to Charlene first.
Thank you. I was clicked unmute and it didn't unmute right away. So the usual things, but anyway, I am Charlene Abrahamson, and I thank you all for attending. I looked a little bit at the website, and the types of things that people are here to learn and are open to learning is really encouraging to me. I am a Spokane tribal member working for Squaxin Island, and I've been here for about 3 years, but I also worked here previously. So there are a lot of great community members that I know and who we mutually consider each other family. Prior to moving over to this side of the state, I was treatment director at the Healing Lodge. So I've worked a lot in behavioral health, addiction, and social services for a long, long, long time. I have 4 grandchildren, so, but you know, we start young too. So I was gonna say that gives you an idea, but thank you. Hey, Rudy. And hopefully I'll be able to bring some new perspectives and some helpful knowledge today. Thank you.
Hi, I'm Don Balmer. I'm the Associate Medical Director at Digualich Wellness Center in Anacortes. Digualich is an integrated treatment facility owned by the Swinomish Indian Tribal Community. We opened in 2017, and in fact, we're very happy to be celebrating our 5-year anniversary today. But Digualich, even though it's a tribal-owned facility, is open to the whole community, and that's based on the traditional Swinomish values of loving, caring, and sharing, and the importance of taking care of the needs of the whole community. And that includes the tribal community, but also the extended community. So in our clinic, we provide primary care, substance use disorder care, mental health care, dental care, and a whole host of client services that I'll talk to you all about. But we provide those for everyone in the community. So you, of course, we have a lot of patients who are tribal, but we also serve non-tribal patients in Skagit, Whatcom, Island, and San Juan counties. But again, I'm very happy to be here. Thank you for having me here, and I look forward to speaking with you all.
Thank you so much. Well, Charlene, I'm going to turn it over to you. Which question would you like to tackle first?
Well, I always tell people that we do speak from the heart, but it doesn't mean we're unprepared. So I read through the different questions. I didn't write anything down, but I think I'll just start with the beginning and how I approach whole person care. And I did see a question in the chat. I just wanted to say maybe try Puyallup Tribes Cancer Services. Sorry, I couldn't let that one go. So as I thought about this, approaching whole person care, and brought to mind clients that we work with and staff and a lot of different people recently and throughout the years, a lot of times what family services is doing is really helping as an advocate, and also offering some protection and translation as people try to get their needs met. The system is pretty one-sided, and there are often microaggressions and straight up aggressions that people have to deal with when they're in a very vulnerable moment. And I know a lot of people have experienced this, and this is why there's been ongoing work for many, many years and moving to tribal DCRs. But a common one is the person that you have to see in order to get access to services that a person in crisis might need. And often just really misinterpreting the signals from a Native person, or mistaking calmness or seeming calmness, or lack of saying very much as someone not being in crisis. So that's an example of throughout years and years and years that that I've tried to deal with. And then also, I guess the stigmas and the being dismissed depending on what service they're trying to access. And I was debating on saying this, but that can be true in IHS care as well if somebody's working with their own clinic, just because the providers that come in don't necessarily have that tribal experience. So then someone might be coming back to me or to different people on the team and saying, well, I tried to get this done, or I tried to do this, and they told me A, B, C, and D. And so then we're working with them to try and go back again, or maybe having releases in place and working with them to help speak. And of course, ideally, that wouldn't happen, but that's where we really do want to see that the whole person is getting treated. So often, and I'm sure a lot of you providers experience this, and Donald as well, that when somebody's been in the middle of addiction or mental health or both types of crisis, there's many things that don't get met around medical types of issues. And we really like to see people access all of that type of care. So it's really protecting, being informed, helping them be informed and navigate the systems. And what I always say about family services, and we have a ton of different programs. We have elders, we have ICW, we have victims of crime, community healing, voc rehab, child care, and hopefully I'm probably forgetting some, but there are so many. So we have either all tribal member staff or other tribal like me. And so what I would say is that they don't have to walk in two worlds when they come in the door. And I would say the paperwork is the colonizing piece. We have to get the paperwork done and the intakes, and a lot of our funding is grants. So it's the same when they have to go out. And one of our strengths as Native people is walking in two worlds and being able to do that well. But one of my goals is to make that less harmful rather than us having to be really great at doing it. How do we make it less traumatic and less of a negative impact on our people, and also, build up those skills. I hope that makes sense. And I put a timer on, so I'm at 5 minutes and I'll stop there.
Oh, no, you do not have to self-time. Don't worry. That's really great. Those are all good. Thank you. Donald, how about you? What question spoke to you first?
Yeah, thank you, Charlene. I'll follow up on the whole person care and behavioral health needs first as well. Tried to do at Deagual Leach to address whole person care is to really try to integrate as many services as possible under one roof so that folks don't have to struggle to get all of their different needs met. So while all of our clients come to us with substance use disorders, a lot of them have had difficulty in the medical system, with stigma, with not getting their needs met. So we have primary care for them, dental care, and mental health services. And when patients assign them to a care team that includes people from all of these different departments to kind of normalize it as, oh, when you're coming here, yes, we realize you have a substance use disorder, but we don't just see you as somebody with a substance use disorder. We see you as a human being who may need all kinds of care, and we want to listen to you and find out what's important to you, what you need, and then help you with those things and make your, focus on your priorities. So all of our patients, are assigned to an RN care manager, kind of the leader of their care team. And in addition to their healthcare provider, their substance use disorder counselor, mental health care, kind of helps that person navigate through all those services. We also have peer counselors that do that as well. A couple of big things that we've found to be really important is to immediately focus on barriers to care. So folks that have transportation issues, who are unhoused, who might not be getting adequate nutrition, just kind of realizing, all these things as really basic barriers that may prevent them from getting any kind of care whatsoever. So we immediately try and find them transportation. We offer transportation services. Involved with so that we know that they can get a nutritious meal while they're here, as well as helping them with other services in the community. We also provide childcare, and that's a huge thing. Patients care about the kids, and they will not come to services oftentimes if they have competing needs. And I know Cindy mentioned earlier the importance of mothers and children, and that is absolutely the case. So we want to make sure that those needs are taken care of for folks so that they can engage fully in services and not being worried that their children are not being taken care of. Another thing that we're moving towards here at Deagual Leach is kind of an opt-out model for mental health, behavioral health care, because there's not only is there a lot of stigma around substance use disorders, there's still, though it's getting better, stigma around mental health care. And so part of what we're trying to do is just normalize having a mental health provider as part of your normal care, just like you would take, you would go to your provider for a physical or a well person checkup, or you would go to your dentist for dental care, well, why would you not have somebody part of your care team who can help you with any of your mental health needs? The other thing that, you know, we've, especially in our population, is both the substance use disorder population and the Native population, is that close to, you know, 50% of people with a substance use disorder have untreated PTSD. So, and then that number is even higher for tribal folks. So we've made early screening and intervention and trauma-informed care kind of centerpieces of helping folks right when they walk through the door, because we know that if they're not getting help in all these areas, the likelihood of being successful in any one of them goes down quite a lot. So we want them to be successful on all fronts. Yeah, we also just, you know, we try to provide other client services as well. Sometimes patients just need you know, they need just a little bit of help figuring out where to access services in the community, or may not realize that they're eligible for more things that they are. So we have, you know, a client services department that works with our nurse care managers, works with our substance use disorder department. So when we start, you know, even patients may just mention something offhand, we make a note of that, and, you know, say, can we help this person with this particular issue? I mean, getting their driver's license, being able to go to the grocery store, whatever it may be, and try to build that into their care plan every bit as much as we try to build in something like, you know, making sure that their hypertension is treated. So yeah, so that's some of the ways that we're really trying to focus on, you know, the whole person needs of all of our patients. Yeah, thank you.
No, thank you. It's always inspiring to hear the work being done there. Charlene, what do you think about one of the other two, either the practices looking different from non-tribal providers, or the working across systems when you have somebody who ends up kind of, you know, a foot in both worlds?
They both tie together in a way, but I'll go ahead and just go in order. So I think what looks different is a lot of times, of course, the people that we serve, some of our programs, we serve only tribal members, some are open more to the area, and other tribal and descendants, it just depends on the program. But generally we have a really good feel of someone's background, you know, going back a long time and knowing maybe who their grandparents are, who their parents are, you know, just a lot of different things that may have impacted them along the way. So I think that gives us a really good vision on what we try and do. And with that, we always look to not enable. So how do we get someone on a path to success? So we don't want any door that someone comes in to be the wrong one, no matter who they call. So we have a screening form. So no matter who someone calls, then we fill out a screening form on their needs, and then we staff it within 24 hours, except on weekends, for across the different programs to see what can help. And with that, everybody would have their intake, and then depending somewhat of an individual service plan or individual success plan. So it's not just coming in, here's a food voucher, here's a gas voucher, or help with utilities or childcare or something like that. And we have a DV program as well, but also then how do we keep engaging them and looking to continue to get to some self-sufficiency, no matter what it looks like. You know, I think I heard a little bit of the previous one, but I've said it a lot too, and I know a lot of tribal providers say this, but our way of knowing is really good enough. And maybe it's just getting in touch with that. Maybe it's treaty rights, income, or however that looks to get to a good stable place. So and I'm sure other providers do this non-tribal, but we really talk about when someone wants to jump in but they were crying, and it's like, well, so trying to just provide something without engaging them, was that to make you feel better or actually helps them? So we talk about that a lot in our program. And also those who know me have probably heard me say this before too, but you can help someone to death, literal death. So it's looking at what can you do that's really empowering someone. I think that's, it's kind of an overused word, but and then word gets around too. It's like, well, you just don't go in and then they do this and this, or you get a check for this. It's really, and sometimes, they take it, we don't hear from them again, but then they know what, till, 6 months or so later, but then they know that we really want to see that kind of engagement. And so I think where that stems from just looks really different from non-tribal providers for knowledge of family, for just people understanding the kind of trauma. And a lot of times you'll go to trainings and they'll be about how do you handle second-hand trauma? And I always say, well, we're at a third level tertiary, because a lot of what our people are coming in with are things that we've experienced as well. And so it reminds us of our traumas and issues, as well as trying to work to serve theirs. So taking care of each other as well, and debriefing with each other as needed. Sometimes just having an immediate meeting after something to debrief and look after each other. And I guess the part that looks different there is sometimes, depending on who we're meeting with on a state or federal level, there can be straight up racism to microaggressions to things that we just need to immediately debrief and make sure that as providers, we're able to continue to do our work. And I'll stop there.
Great. No, thank you. Thank you. Thank you for sharing that insight and how you work with the team to support each other with that. Thank you. Donald, how about you?
Some of the things that, of course, almost all of our services are available to all of our clients, both tribal and non-tribal, but some things that we have set up that I think are definitely different than non-tribal programs are, we have as part of some of our group offerings, we have a lot of classes, like, for example, we have Native Arts class, beading and drum making. We have speakers come in from Swinomish, sometimes from other tribes, to talk about food medicine, plant medicine, kind of traditional practices that can absolutely be incorporated as part of their medical and spiritual care. We have, because I think in most tribes, like, the reverence for elders is so high. We have elder coaches here, so that tribal members can talk to their elders and that they're available to them, to be on them, and just to help give them some additional support. We do have so while we have all sorts of kind of traditional programs for people with substance use disorder, we also offer the Red Road to Wellbriety program, which is a 12-step program, but that's really focused on a tribal perspective. We have men's and women's talking circles that are led by elders. And I think just on some logistics levels, one of the things that we have here is for most of us who have worked in more traditional medical clinics, schedules are very rigid. And here we understand that when somebody needs help is they're going to come when they're ready, and we need to honor that and be ready for them when they're ready. So we try to make work it into our schedule so that we can be as flexible as possible to accommodate somebody. Yeah, maybe they were scheduled at 8, but 11 o'clock is when they're here. And that's when we're going to see them, because we need to make sure that we're able to get them care when they need and are ready for care. I think I mentioned this before, and I know Charlene mentioned this, but really focusing on trauma-informed care, and really making sure that it's built in so that we actually have time to listen to people's stories and listen carefully and give them the time they need to tell us what they need to tell us, rather than, oh, I've got my 15 minutes with you and sorry, that's all for today. No, we flex things to make sure that we can spend the time with people that we need to. The other thing that we do is we try to make sure, tribal rights, fishing rights, treaty rights are very, very important and sources of cultural pride. And we do everything that we can to prepare for, like, for example, when fishing or crabbing season comes, to make sure that we can help our tribal folks be able to participate fully in those activities while still getting the care that they need. So those, I would say that those are some of the ways that we probably look different than non-tribal programs.
Excellent, thank you. And if you were to, I know we're running up on time, but if you wanted to close out with any tips that you have for people who are kind of in your system, but then also end up in the state system as well, we're accessing county resources and working across systems.
Well, for me, that's really, you need to get to know a lot of different people and all the different systems and who to refer to. And I'm sure there's sometimes people regret that I have their cell phone number or something, and I'm texting them at 9 o'clock at night and like, what the heck, this responder, this DCR, I don't really saw this clearly, and that type of thing. Just really being able to access so many different people and getting to know those people and having them get to know you. There's once I was at Chehalis, I was the behavioral health director there. My counselors came to me and said, well, we called this, and but they told us that they can't serve or they can't help with this. And I said, okay, well, give me a minute and I'll call. And because I had something going on, and about 10 minutes later, they came back down the hall and they said, oh, they called back and they said, Chehalis, where Charlene is? And they said, yes. And they said, oh yeah, we can get this done. So kind of making yourself that person that it's like, okay, this is someone who's not going to let go of something. So it doesn't mean that I yell at people or, gossip about them or things like that, but I'm a strong advocate for people. So I guess that would be my number one tip to that. And then what you can teach through that. So, I do try to teach people things, and I'm meeting at schools, I'm meeting with many, many people across the board, but I did have a white vice principal tell me recently, because they got an email from the placement about the youth, and that they were calling out, why did, of the 5 youth involved, the 3 brown kids were sanctioned and put out of school. And so anyway, we're meeting about that, and he was very riled up, but he just said, well, I found that email really racist, and then kind of looked at everybody like, what do you have to say about that? And of course I bit my tongue and I didn't say, well, you're white, you can't face racist things or anything like that. But what I said was that I read it differently, that how I felt about the email was that these are things that we go through that we can bring up because it's a safe place. So if you look a generation back or a few generations back, you, as Native people, we would just have been told not to bring it up. I can just picture my grandma even saying that, like, no, just be quiet, don't, so that I felt the way I read it, that it was a safe space to discuss these things. So it really turned the conversation around, and hopefully he did actually say later that, well, I can't ever say that I understand how that feels or how certain things feel. So it's not just accountability, but also, is there something you can teach? Sometimes there's not. I would say, don't bang your head against a wall or do harm to yourself if it's just a system that won't move. But if you can provide some education along the way, I think that's really useful too. And thank you.
No, thank you. Thank you both so much for joining us today. Thank you, Lisa, for all the organizing and getting us all here. And I saw a couple of questions in the chat. We'll make sure to put those on that FAQ page that we've been talking about. And then I want to make sure that hopefully Samantha Flourish heard Charlene's comment about the Puyallup Salish Cancer Center could be a good place to try to check in with them.
And I just, sorry, I know there's a time crunch, but I saw Rudy's comment about journeys and land and things like, and yes, we do try to do that, of course, during COVID. And it sounds like, Donald, that they do transportation as well. And it is really useful. At the Healing Lodge, I had youth, if there was something, I would call it river therapy. And I'd take them by the river and we'd walk, and then it'd be amazing how often they'd say to me, it really is therapy. And are just repotting a plant. I had a youth who was just super angry, and I was like, oh, I understand, I want to hear you. Can you help me repot this plant? And he's like, yes, blah, blah. And as soon as he got his hands in the dirt and started talking, his whole mood changed. So thank you for the question, Rudy. And sorry, I just wanted to add that.
Thank you all
No,
for
I
having
loved it.
me. I really appreciate it. And I know we're out of time, but I also just want to mention that I dropped my email into the chat. So please don't hesitate to reach out with me if you had any other questions or wanted to talk more about any of these issues, or about local partnerships here with us.
Thank you so much, Catherine, Donald, Charlene, Vicki, and everybody at the commission, and to all of you who have participated. It's been a wonderful, uplifting, and sometimes challenging 5 sessions, and I know I've learned a lot. We will be reaching out to you, or Allie will be reaching out to you, for those of you that want continuing nursing education, about the process for that. So thank you all so much.
Thank you.